Imagine your tissue is so severely dry that it is physically tearing. It's fragile, it's painful, and it's heavily impacting, your daily life. And the proposed medical solution,
Yeah.
fire a high-powered laser directly at the problem area.
Yeah, which sounds completely counterintuitive. I mean, everything we know about basic biology tells us that you don't use intense heat and light to cure a lack of moisture, right?
Exactly. I mean, the immediate assumption is that a laser is just going to vaporize whatever moisture is left. You picture it like burning the tissue and leaving things far more desiccated than they were when you walked into the clinic.
Right, that's the gut reaction for
Yeah.
sure. But we're looking at a massive stack of medical sources today that are pushing back against that assumption.
Yeah, we have this huge deep dive for you today. We've got clinical guidelines from major urological associations, safety data overviews from the UK, protocols from active clinical trials, and of course, promotional material from women's health clinics.
And all of this material is focused on one specific, highly controversial frontier, which is using laser technology to treat severe vaginal dryness, particularly for patients who are recovering from cancer treatments.
Right, and there is a profound divide in the medical community right now. To give you a sense of the landscape, we are comparing two leading technologies side by side today. One is the ablative CO2 laser, and the other is the non-ablative YAG laser.
Yeah, the ERAG. And our mission here is to understand how the underlying mechanical differences between these two lasers translate into radically different recovery timelines.
Right.
And ultimately, whether either of them is actually safe for tissue that has already been compromised by heavy cancer therapies.
Because the desperation driving this market is incredibly real. On one side, you have these enthusiastic clinics marketing this as a 5-minute miracle cure with zero downtime.
Oh, yeah. The marketing is very aggressive.
Yeah. But on the other side, regulatory bodies are waving giant red flags and pointing to instances of severe permanent scarring. So to understand how we got to this polarized place, we kind of have to look at why these patients are seeking this treatment to begin with.
Well, the clinical term we are dealing with here is genitourinary syndrome of menopause, which is commonly referred to as GSM. The defining symptoms are severe vaginal dryness, chronic itching, and significant pain during intercourse.
Right. And for a large portion of the population, this happens gradually, as estrogen levels naturally decline during menopause. But the sources we are synthesizing today focus on a uniquely vulnerable group.
Exactly. Survivors of breast, cervical, or endometrial cancers.
Because the therapies that save their lives, pelvic radiation, systemic chemotherapy, or long-term endocrine therapies, they plunge the body into sudden aggressive menopause. We aren't just talking about mild discomfort here.
No, not at all. The dryness is a profound, persistent side effect that alters their entire quality of life, and the standard medical playbook just doesn't really apply to them.
Right, that is the core dilemma, isn't it? Because for a standard case of GSM, the first-line defense is usually just a topical vaginal estrogen cream.
Yep. It works really well to restore the local tissue. But, and this is a massive but, if you are a breast cancer survivor whose original tumor was hormone dependent, introducing any form of estrogen is often strictly contraindicated.
Oh, wow. Because it could feed the cancer.
Exactly. The medical community simply cannot risk fueling any microscopic, dormant cancer cells. So, these patients are locked out of the most effective treatment.
So they are essentially told to manage it with over-the-counter moisturizers, which, let's be honest, barely scratch the surface of post-radiation atrophy.
They don't. It's that massive gap in care and that daily physical pain that pushes patients toward these energy-based devices.
But before we get into the mechanisms of these lasers, there's a huge point of anxiety we need to clear up based on the clinic FAQs in our stack. Because if a patient has just survived pelvic cancer, the last thing they want is to be exposed to more radiation.
Oh, for sure. The terminology used in energy-based medicine can definitely cause some panic.
Yeah.
But the clinics and the technical specs are very clear on this safety point. Both the CO2 and the YAG lasers emit infrared light energy.
Okay.
They do not emit ionizing radiation. That means they don't have the type of energy that damages DNA or causes cellular mutation.
That's a crucial distinction.
It is. There are zero radiation safety concerns with the lasers themselves. They are purely delivering targeted heat and light.
Okay, I want to look closely at how that targeted heat actually creates moisture, because I'm looking at the mechanical description for the CO2 laser, and it's called a fractional ablative laser.
Right.
Now, ablative usually means destroying or vaporizing something, which sounds incredibly aggressive for tissue that is already, thin and fragile.
Well, it is aggressive, and that's entirely by design. The CO2 laser works by vaporizing a micro-thin layer of the tissue surface.
Wow. Vaporize.
Yeah. And the term fractional means it isn't burning the entire surface area. Rather, it's creating a grid of tiny, controlled micro-injuries. It punches microscopic holes into the vaginal wall. The laser's heat specifically targets the water molecules in the tissue, instantly boiling them to create that vaporization.
But our sources emphasize that the protocols keep the temperature strictly regulated, right?
Mhm.
Between 45 and 60 degrees Celsius. So they are walking a tightrope to prevent widespread thermal damage. They are intentionally damaging the tissue just enough to force the body into a panic state.
That panic state is the actual mechanism of action. When the body registers those micro-injuries, it assumes it has suffered trauma and launches a massive, localized healing cascade.
Okay, so it tricks the body.
Exactly. This triggers fibroblasts to start working overtime, leading to neocollagenesis, which is the production of new, tightly woven collagen, and neovascularization, which is the sprouting of new blood vessels. You're essentially tricking the body into sending fresh blood flow, elasticity, and natural moisture back to a lining that it had previously abandoned.
Right, so that is the ablative CO2 approach. Now, our sources contrast this heavily with the YAG laser. This device is categorized as non-ablative, or photothermal,
Yes.
and the technical data mentions it uses pulse stacking and smooth mode technology to deliver repetitive, low fluence energy. Let's clarify that real quick. What exactly does fluence mean in this context?
So fluence is essentially the concentration of the laser's energy over a specific area. Think of it as the intensity of the light hitting the tissue per square centimeter.
Oh, got it.
So by using low fluence energy, the EOR-YAG laser delivers a very gentle, controlled heat. Instead of vaporizing the tissue surface, it creates a deep, uniform bulk heating in the deeper layers of the vaginal wall.
Wait, so it doesn't break the skin at all?
Nope. It heats the existing collagen fibers so they contract and tighten immediately, and then stimulates that same long-term collagen production, all without breaking the surface mucosa.
Okay, let's unpack this. So if we look at the physical difference, the CO2 laser is essentially like aerating a lawn by pulling out tiny plugs of dirt to stimulate the roots and get the water flowing right.
It's a great way to look at it, yeah.
But the ERYAG laser is more like using a specialized heat lamp to bake the soil underneath, stimulating the roots without ever breaking the blades of grass on the surface.
Exactly. And that physical difference, the aeration versus the subsurface heating, is what drives everything else in this clinical data. Because the actual mechanism of injury is different, the way the body recovers is entirely different.
Which brings us perfectly to our specific focus today. How do these distinct technologies compare when it comes to the recovery timeline, especially for a patient dealing with severe post-radiation dryness? Because if you are already fatigued by chronic pain, you really need to know how long this procedure is going to put you out of commission.
Right. Well, the actual time in the chair for both lasers is remarkably fast, usually about 5 to 15 minutes in an outpatient setting.
That is fast.
It is. But the minute the patient leaves the clinic, the differences become glaring. Because the CO2 laser is ablative and has physically vaporized tissue, it leaves open micro wounds. Healing those wounds requires strict pelvic rest, which our sources peg at anywhere from 3 to 10 days, depending on the clinic's protocol.
And reading through these post-care instructions, pelvic rest is incredibly comprehensive. Like, patients are instructed to avoid sexual intercourse, they cannot use tampons, they have to skip hot showers, and no swimming pools or baths.
Yeah, it's very strict. They are trying to prevent any kind of infection from entering those microchannels while the tissue knits itself back together.
And furthermore, during that initial 24 to 36-hour window, patients often report mild irritation, stinging, and a watery, sometimes blood-stained discharge, right?
Yes, the tissue is inflamed. Although the clinical guidelines point out that the vaginal mucosa heals incredibly fast compared to regular skin. For context, if you used a CO2 laser for external skin resurfacing on your face, you would be looking at 14 to 21 days before you could comfortably return to work.
Oh, wow. So 3 to 10 days is fast for CO2, but it's still a significant disruption.
Exactly, especially when you compare it directly to the ERYAG laser. Because the ERYAG relies on that non-ablative deep heating because it never breaks the surface of the tissue, the downtime is drastically reduced.
Right. The sources cite a recovery window of just 24 to 72 hours of pelvic rest. So you are avoiding intra-abdominal pressure and intercourse for maybe 1 to 3 days tops.
Yeah, the treatment itself is usually described just as a deep, warm sensation. The side effects afterward are minimal, perhaps some mild redness or swelling, but nowhere near the inflammatory response of the CO2 laser. You're generally back to your normal routine almost immediately.
But looking at these two recovery timelines, there is an obvious question staring us in the face here.
What's that?
If the non-ablative ear YAG laser is gentler, doesn't break the tissue, and gets you back to normal life in a fraction of the time, why would a doctor ever recommend the CO2 laser? Does the physical tissue damage from the CO2 aerator actually prompt a more robust, long-lasting healing response than the heat lamp?
You're hitting on the core debate in urogynecology right now. The decision between the two is heavily dependent on the severity of the patient's atrophy. The CO2 laser is frequently positioned for patients with highly significant, visually apparent surface symptoms.
So really severe cases.
Exactly. If the tissue is profoundly thin and fragile, the theory is that you actually need the aggressive microablation to force a dramatic enough biological reset.
Oh, I see. So it's a calculated trade-off. The patient and the provider accept a longer, stricter, more uncomfortable recovery period with the CO2 laser because they believe the sheer physical trauma is necessary to kickstart a deadened healing cascade.
Right.
Whereas the ERYAG is preferred when deep heating is deemed sufficient for mild to moderate symptoms.
That is the theory presented by the clinics and device manufacturers, yes.
Yeah.
But that theoretical trade-off brings us to the most startling aspect of our source material. We've mapped out how the mechanisms dictate the recovery clocks. But there is a fierce divide over whether either of these devices is actually effective or safe in the long term.
It is wild how polarized the data sets are. If you read the marketing materials and the clinic reports, you see glowing clinical evidence. They claim up to 90% patient satisfaction.
Right.
They highlight significant improvements in the vaginal health index, which is a clinical metric measuring elasticity, fluid volume, and pH balance. They point to drastic reductions in painful sex.
And the broader medical community is taking that potential seriously, which is why we are seeing large-scale investigations like the Revitalize trial.
Yes, the Revitalize trial.
Right. This is a massive phase 3 clinical trial actively enrolling 250 women who have a history of breast cancer. Their goal is to formally test the ablative CO2 laser against a placebo procedure to get high-quality randomized data on whether it genuinely improves vaginal dryness and overall quality of life.
I found the methodology of that trial fascinating, by the way. How do you administer a placebo laser treatment? They can't just pretend to turn the machine on, can they?
Well, actually, they use what's called a sham intervention. The clinical probe is inserted into the vaginal canal and moved in the exact same pattern it would be during a live treatment, but the actual laser energy mechanism is disabled.
Wow.
So the patient hears the machine beep, they feel the physical manipulation of the probe, but they receive zero energy. And this sham design is critical because the American Urological Association guidelines highlight a massive confounding factor in these studies.
Which is?
The placebo effect for this specific condition is astronomically high.
Yeah, the sources drill down into why that placebo effect spikes so dramatically. In many of these trials, the researchers use vaginal lubricating gels to safely insert the sham probe, or they give the control group basic gels to use during the study period, right?
Yeah, that's exactly it.
For a woman suffering from severe untreated atrophy, just the act of participating in a medical trial, having a doctor actively listen to her pain, and receiving the mechanical hydration of a thick ultrasound gel, that alone causes a massive reported improvement in symptoms?
It muddies the empirical water significantly. When the American Urological Association analyzed studies that directly compared the CO2 laser to these sham interventions, they concluded that the laser itself may result in little to no actual clinical difference in symptoms like painful urination or overall quality of life when measured against the placebo.
Wow, so the mechanical gel and the psychological relief were doing all the heavy lifting.
Basically, yeah.
And this leads us to the regulatory red flags, which are jarring to read side by side with the clinic marketing. Like, one clinic in our stack explicitly claims to have performed 2,000 treatments without a single patient experiencing scarring.
Right.
But then you flip to the official guidelines from the AUA and SUF, that's the Society of Urodynamics, Female Pelvic Medicine, and Urogenital Reconstruction, for those keeping track of the acronyms. They explicitly state that current evidence does not support the use of either CO2 or ER-YAG lasers for treating GSM-related dryness.
They issue a formal, moderate recommendation against their routine use. They actually label these therapies as experimental outside of clinical trials. And it's important to understand the regulatory nuance here. The FDA has cleared these laser devices for general surgical applications like cutting, vaporizing, or coagulating tissue in a standard operating room.
Right, as tools.
Right. but the FDA has not approved them specifically for the treatment of menopause symptoms or vaginal rejuvenation.
And the National Institute for Health and Care Excellence, or NICE, over in the UK, compiled an overview that heavily references the FDA's MAD database.
And just to clarify, MAD stands for Manufacturer and User Facility Device Experience. It's the central public repository where doctors, hospitals, and patients report adverse side effects and malfunctions associated with medical devices.
The adverse events detailed in the MAD database regarding these lasers are severe. We aren't talking about mild irritation or a slightly longer recovery time here. We are talking about third-degree burns and permanent vaginal mucosa scarring.
Yeah, it gets really grim.
Patients are reporting persistent and worsening dyspareunia, meaning sex becomes exponentially more painful than it was before they sought out the treatment.
And the NICET overview includes one particular case series that illustrates exactly why that strict recovery timeline we discussed earlier is a matter of profound medical safety. It details the case of a 65-year-old breast cancer survivor suffering from severe dryness.
Okay.
She underwent a series of 3 CO2 laser treatments. She engaged in intercourse a few weeks after her final session, which was technically outside the mandatory pelvic rest window, but her tissue suffered severe vaginal wall laceration.
Oh my God.
Yeah, and several months later, her vaginal canal had become foreshortened to about 2.5 centimeters due to dense fibrotic scar tissue.
That is a devastating outcome. Why did the tissue react that way? I mean, we talked earlier about neocollagenesis and the body sending fresh elasticity to the area. Why did her body lay down rigid scar tissue instead?
Well, that case represents the absolute worst-case scenario of thermal damage, particularly in a patient whose tissue is already compromised by cancer treatments. Post-radiation tissue has poor vascularity, the blood supply is already weak.
Oh, I see.
When the CO2 laser vaporized those microchannels, creating physical wounds, her body just didn't have the resources to regenerate flexible, healthy collagen. Instead, it panicked and healed the trauma with fibrosis, which is stiff scar tissue.
Right.
So when she resumed intercourse, that stiff tissue tore, healed with more scar tissue, and eventually contracted the entire canal.
It's a stark reminder that when you intentionally damage tissue to trigger a healing response, you are entirely at the mercy of how well that specific patient's body can heal. You are looking at a landscape where women suffering from debilitating post-radiation dryness are caught in the middle of a massive medical tug-of-war.
They really are.
Clinics are offering relief, while regulatory bodies are pointing to third-degree burns. How is a patient supposed to navigate a landscape where the marketing and the medical guidelines are practically speaking two different languages?
Well, the guidelines point to shared decision-making as the only path forward here. The AUA does leave a small window open. They acknowledge that in the context of extensive shared decision-making, and with full documented disclosure that the therapy is experimental and carries the risk of thermal injury, a clinician might consider laser treatment for patients who absolutely cannot use FDA-approved treatments.
Which brings us right back to our breast cancer survivors who are barred from using estrogen creams.
Exactly. For a patient with 0 other options, the risk-benefit calculus is entirely different than it is for someone simply seeking, cosmetic rejuvenation. But the burden falls on the patient to look past the glossy marketing of 0 downtime. They have to fundamentally understand the specific mechanism of action. Is the provider using the microablation of the CO2 laser or the deep heating of the ER-YE? They need to comprehend the potential risks of thermal damage. They must ask their provider, what is your specific complication rate? And what exactly happens to my anatomy if I heal poorly?
It's about demanding to be deeply informed, rather than just being sold a procedure. And that's what we've tried to untangle for you today on this deep dive. We've mapped out the fundamental mechanical differences between these two devices. We have the CO2 laser, the ablative tool that intentionally vaporizes microchannels into the tissue, acting like a lawn aerator.
Yep.
And we have the non-ablative ERYAG laser, which utilizes deep thermal heating, acting more like a heat lamp baking the soil underneath.
And we explored how those mechanical differences dictate the reality of the patient's recovery. The physical tissue damage of the CO2 laser requires that strict 3 to 10 days of comprehensive pelvic rest to allow physical wounds to close.
Right.
While the non-ablative ERAG offers a much faster 1 to 3 day turnaround by leaving the surface intact.
But the choice between that aggressive ablation and the gentler heating sits right in the middle of a turbulent debate over safety. It's a tug-of-war between high clinical satisfaction rates and strict regulatory warnings about high placebo effects, scarring, and severe burns.
Ultimately, As you evaluate complex medical interventions, particularly for vulnerable populations recovering from systemic illness, understanding the exact mechanism of action is your greatest defense. Knowing the profound biological difference between ablation and non-ablation is the key to accurately predicting both your recovery timeline and your true risk exposure.
Yeah.
You cannot just focus on the desired outcome. You must interrogate exactly how the machine plans to get your biology to that finish line.
Which leaves us with one final provocative thought for you to mull over. The entire premise of these lasers, the reason we are firing intense energy into delicate tissue, is to intentionally injure it, either through vaporization or deep heat, right?
That's the idea.
We are relying entirely on the body's natural panic response, that intense healing cascade, to produce new collagen and moisture. But if the medical community knows exactly what biological cascade they are trying to trigger, could future medicine figure out a way to chemically or biologically trigger that exact same healing response?
Oh, that's an interesting thought.
Could we eventually bypass the need for physical laser burns, thermal damage, and strict recovery times altogether?
Finding a way to signal that regeneration without the trauma is really the holy grail of regenerative medicine, and it's a frontier we should all be watching closely.